Herzlich willkommen. Sie hören die Kunst von Notfallpflege.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thanks for listening to the podcast. I, as always, appreciate you listening. Don't forget, what we need you to do here at the podcast is we need you to rate and review the show if you haven't done so already. And we also need you to share this show with your friends. Share the show with other emergency nurses that you think could use the advice and wisdom that we are sharing on this show. My guess is by the intro to the podcast, you have guessed that this is yet another international nursing episode. And you're absolutely right. My guest today is a nurse who works in Germany. Now, he was not born in Germany, but he's going to share with you his international journeys and what brought him to Germany. He's going to share with you some of the differences in being a nurse in Germany compared to other places and share his perspective from not only there, but from other areas as well. You are going to love this episode with my international friend, Walter.
Hi, Servus. My name is Walter Dugari. I am an emergency staff nurse. I work bedside in a small hospital in a 160,000 inhabitant town here in Germany. But I am not native German. I am half Filipino, half Italian, and actually finished my bachelor's in the Philippines. So I also have a little bit of experience in Italy. And I've been working in the emergency department since 2017, 16, 17. Before that, I was a urology nurse, believe it or not.
No kidding. Holy cow.
Yeah.
That's a big leap from one to the next. Totally. You're like, okay, I'm bored with this. Let's go the other extreme. Because I would imagine, well, I mean, urology emergencies are a thing, and that's probably a lot of what you see, but I just can't imagine a different world.
Well, the thing is, working in urology, it was actually quite a interesting story because of the fact that we were having a merge with another station. So it was going to be they get to pick who gets to stay, and the rest could decide if they want to leave voluntarily and change stations. I actually applied for the ICU,
Okay.
strange enough.
Yeah.
And unfortunately, they did not give me the position, rather choosing a new grad. And they told me out of nowhere the week after, it's like, oh, by the way, you're starting next week in the emergency department.
Were you like, oh my God, no?
Absolutely, yeah.
were you like, oh my gosh, this is going to be, because like, what a culture shock.
Absolutely. The fact is, I was already used to having this kind of station mentality wherein you have your patients, you take care of your patients for a certain period of time, you see the progress or you see the regress, depends on the patient, and you help the patient come to the best possible position, either to leave your station in one way or another.
Sounds like emergency nursing, maybe to some degree. Now, were you inpatient urology? Inpatient?
I was inpatient urology. That means every single patient that I had were usually either taking chemotherapy or they had extensive operations that were really, really complex. But most of the time it was very, very easy because once you learned all the entire, standards, like every single operation had a standard. If you knew it from inside and out and what you have to look for,
your day is planned. Your day is just boom, boom, done.
Exactly. But unfortunately, that was not the case. That was, I would say, a really huge sneak attack because our emergency department was not exactly well known at the time as being one of the most caring areas when it comes to, colleagues and, how we, interact with each other. We're not really they would say it's kind of like a sandpaper situation. You get in and you just get scratched.
Gotcha. Now,
So yeah.
now, so so your unit was changing, and I, I, I guess so they didn't give you a choice. It was like, here's what you're gonna do.
Oh, they gave me another choice to float.
Oh, okay.
Exactly, which was more like
You're like,
uh, mm,
no, not interested in that.
exactly. And so I came in there. Apparently, someone they already talked about me saying, "Oh, he knows a lot of things. He's been working in another emergency department." I was like, who are you talking about again?
Yeah.
I'm not the person. So it's kind of exactly. So it's kind of like this kind of situation. You come in with misconceptions. They have misconceptions about you as well. And so the first thing I did when I arrived was, okay, you're here. Just take a deep breath and start over.
Huh.
So that was the first thing I did. I introduced myself to everyone, took a deep breath, and actually listened, looked, and worked.
Good for you.
So it took me 6 months before I actually decided, you know what?
Yeah,
I
it's
think
gonna be
this
all
is
right.
no, I think this is my area of expertise. I think I'm gonna stay here. I'm gonna stick with it.
That's awesome.
So it was not exactly love at first sight. This was more of, you hated it, but for some reason that hate turned into love, and you don't understand why.
It's like an abusive. I always tell people like being in the ER is kind of like an abusive relationship. You're like you want it to get better, and you think it's going to, but it
Uh, I
go
was
for it.
gonna say, I was gonna actually agree with you, but at the same time say, but there's no honeymoon phase. That's the problem.
No, you just get screwed right away. Like,
So I started actually. So with all the different experiences I've had beforehand, because while I was in Italy, I was working with the Red Cross as a volunteer paramedic.
oh, okay.
I
So you're a paramedic before becoming a nurse?
Not necessarily, because in Italy they don't have fixed positions for paramedics.
Oh, they don't.
They're mostly volunteers,
Okay.
which is okay. It sounds dubious and scary for many people who hear it. It's like, what do you mean?
Uh,
So then it works that way that in many areas in Italy, the entire ambulance system is actually run by volunteers,
I,
which are specifically trained to actually take care of people until a necessary backup from a doctor or a emergency nurse is necessary.
because volunteer EMS is a big thing here, in the U.S. And depending on the community, like so, there's not a lot of volunteers in Houston. Well, I guess there
Mhm.
are, but in New Mexico, where I was before, like volunteer EMS was like that's how most calls get run. But the ER nurses and the doctors don't go out to the scene. That it's the paramedics all the way through, bringing them to the hospital.
Because in, for example, in Italy, we have the 118, which is the general call delivery system
Uh,
for healthcare and healthcare emergencies.
yeah.
So once this number has been activated, so they send a volunteer ambulance with the volunteers in it.
Okay.
They come to, and the volunteers themselves check on the patient, they give the vitals through the phone, and they could say, you know what, I think we need a doctor right now. So a doctor and a nurse will be sent from that
Interesting.
area to do a rendezvous and actually continue the treatment. So it's a way of covering what the volunteers can't do or don't know, whilst providing good patient care.
Okay. I it seems reasonable. It seems like a pretty decent. I mean, it seems like an okay way to do it. It's interesting that it's very different from what we're used to here. Like here, it's all EMS. I mean, EMS is its own specialty. Oh,
Um, the same thing with Germany. In Germany, you have EMS. You also have volunteer
yeah.
paramedics, but the same system works to the point that when the paramedics say, you know what, we need backup, a doctor is also required.
Interesting.
And will have to, travel there. Usually it's an anesthetist or an internal medicine specialist that will do that.
Oh, okay. That's kind of cool.
It is. When it comes to, proper health delivery, at least you're covering what I always say, the major problem when you only have paramedics on, in the practically in the ambulance, is that there is a risk that you cannot cover everything. Depends, what can you do? What can you give? What can you put, can you place an IV?
Yeah.
There are these problems. In Germany, there's some areas where, paramedics are not allowed to place IVs.
Interesting. It's interesting how different that system is from the US, where in the US, yeah, you can do all of that and more
Exactly.
for paramedics. So interesting.
Well,
So you were a paramedic for a little while in Italy.
yes.
That's cool.
Which, of course, that also, shaped a little bit who I was, because of the fact that I was getting so used to emergency calls. So when I started in the emergency department itself, it just, it did not shock me, or,
Like you already knew that.
I
You
already
already knew
knew
that
what I had
piece.
to do.
Yeah.
So in a sense, perhaps that was kind of, a way of saying, hey, I think that's your place. Although it would have been better if they talked with me first.
It's kind of funny how that it's kind of funny how the universe works sometimes. Sometimes the universe puts you where you're supposed to be, whether you want to be there or not. So
So, okay. So I started doing emergency nursing, and eventually I started doing my first traumas, doing the trauma bay, and I slowly actually fell in love with it completely, heads over heels, because of the fact that you realize that every single thing has its place, every single action has its place, and you actually know what you have to do subconsciously, and you actually do it mechanically because of the fact that it just flows.
I
So
I love when you get in that. I love when you get in that point as a nurse and as a team where like things just flow. Like
exactly.
it just goes the way it's supposed to go.
And some of the most wonderful, well, I find trauma based one of the most excruciating experiences anyone could have, that is a newbie.
Yeah.
But at the same time, when it just flows, when you're in that zone of everything that you're in, this flow, that everything just goes one after the other like a cascade, and the patient's going to do well.
Yeah.
The patient's going to just survive it.
That's isn't that a cool feeling? Like it's a cool feeling where you're like going, we have a great team and we're like, we got you. We're gonna take good care of you. You're gonna be okay because you're here and we know how to do this. That's just awesome. What a cool feeling.
It's absolutely that. So that actually started to spark my interest in looking for new outlets, and I stumbled upon ENA online, and I was wondering, okay, this seems like an interesting organization.
Yeah.
So I joined up, started reading, entered this. There is this forum on ENA, which is also quite interesting, the ENA Connect.
Mm-hmm. Yeah.
And all of a sudden, Joop Broya from the Netherlands hits me up and writes in German. And I was a bit perplexed. I was like, I could also write in English, but okay, what's going on?
Oh,
And
didn't expect that.
absolutely not. So, of course, if it weren't for Joop, I wouldn't, get more every single thing that led me to the position I am right now, it's just, how could we say it? It's just like a incidental.
Yeah.
It just happened.
Yeah.
You don't know. There's no cause and effect. It just happens.
Yeah.
And it just got pulled in this direction. I ended up applying for a scholarship and I came to Austin in 2019. And I was overwhelmed, absolutely overwhelmed, seeing all these colleagues from all over the world,
All over the
from
world.
all over the US. I
And
have never experienced seeing 5,000 plus people in one single area. And I was thinking, if they're all here, who's taking care of the patients in their hospitals?
yeah.
It's like they don't have the right to say they're understaffed if they're all here.
Well, and the hard part is like it's a fraction of the people. It's a fraction of emergency nurses that actually belong to a professional organization. And it's an even smaller fraction that show up and get active. You know, I always tell people all the time that there's 50,000 people in ENA, and you probably count the people who do like kind of the work is probably like a tenth of that,
Yeah.
maybe less. So,
But I think that it's a major problem in all volunteer associations
of
when one
course,
comes to it. But just this, you know, mass of people that you've never seen before, that you could never even imagine. I was I was blown away, and it was inspiring listening to people from all over the world, and that actually sparked the interest to go and join up and try to volunteer to give something back. I
it's
mean,
awesome.
I was able to win the scholarship, one of the scholarships that was funded by Jeff Solheim. Again, a very inspirational man.
Shout out to
And
Jeff. Yeah.
and I said, I'm going to try my best, give what I can back so that the next generation can come up. I've been trying to convince all my colleagues at work to join up, but the problem is they're always saying, no, we can't do English. And it's like, shut up. You guys know how to order things online from some website in China, but you don't know how to speak English, please. So um, again, it's been a wild ride, and meeting up, of course, once a month with the International Advisory Committee, which I ended up entering. Again, that is just a shot of pure adrenaline and inspiration, and just saying, you know what? With colleagues, with co-members, with people, leaders such as these, you can go anywhere. You can change the world literally. And it's not being cliche. It's more of, you know what? Let's take it a step at a time, but we will get there.
100%. 100%. I I just can't imagine what that had to be like coming to. And had you been in America before?
Absolutely not.
Okay.
That was that was also my first time in the United States. So that was, well,
What?
it wasn't a complete culture shock. I
Yeah.
mean, we do have our preconception of the US from, of course, entire cultural media that we see, but I think
We're not
being
that
in
bad.
the US is a completely different experience.
Yeah. So that had to be that what a super cool thing to be able to come and see all those nurses. And um I think it was in Austin I met Vanessa from Australia there. Um and we had talked online, talked on Facebook before, but we hadn't met. So we got a chance to meet there, and Yop, of course. We met briefly. I've met briefly somewhere before, but the nicest.
Absolutely.
He's just the
Uh,
nicest. So
the first time we met up, we actually met up in Brussels
okay,
for the emergency conference for emergency nurses in Europe.
nice.
So that was it's actually supported. OISEN, the European Society for Emergency Nursing, is supported actually from ENA as well. So
Nice.
it's actually quite interesting.
Very cool.
It
Yeah.
was the first conference they ever did, and that was also interesting to see, European nurses.
Yeah. I bet because that's such a broad variety of places
Absolutely.
and
We always
completely different, probably completely different healthcare systems, completely different
Absolutely.
models.
So the first time I arrived in Germany, people always say, you're going to experience you all every single time. I'm used to culture shock since I was a child, but when I arrived in Germany, I kind of had a preconception, because you read up before you transfer. You should read up at least before you transfer.
100%.
So I arrived in Germany, and of course, the first thing you're going to notice is the fact that the language is 10 times harder than what you think it is.
Okay.
And that's something you have to do. Then when it came to the healthcare system, every single person that is in Germany is, according to law, required to have a health insurance.
Yeah.
That is an absolute. There's no questions about it. That means even if you're unemployed, there are health insurance companies that are they're supposed to give it to you.
Yeah.
Nonetheless, it will be supported through tax,
Okay.
through
That's
the
it. That's what I was going to ask, is if it was a federally funded, government funded.
it is actually all insurance companies except a certain part, which I'm going to explain a bit later, are actually all they're not government. We call them as public insurance, health insurance,
Gotcha.
right? So that means every single person that works under an employer or is how do we say unoccupied unemployed would have an insurance. Either it's covered by the job center, which is the equivalent of, if you lose your job, you have to go to the job center and you get registered so that you
Gotcha.
can get benefits.
Yeah.
And either that, or you get directly from your employer,
Yeah.
which the employer pays a part of it ahead of time, and a part of it comes from your salary itself.
Yes. So
So,
similar to America.
and private insurance costs actually less because you have to pay it yourself
Yeah.
to them. You have to pay, the parts, and you have to give, in case you go into hospital, you have to give some money to cover some, and then you get reimbursed. You
Okay.
pay ahead, more or less.
Yeah.
While the other one, once you go into the hospital, you only pay for, being in the hospital, which is usually maximum 10 euros a day, which
Okay.
is equivalent to $12.
That's nothing.
It's nothing. I mean, when we're talking about, healthcare systems, especially when we're talking about healthcare insurance, we should not forget the fact that many countries in Europe, especially, for example, Germany, Italy, France, the Scandinavians, they are all based on this principle, welfare state. So that means every single person has the right to get cured and not go out of the doors bankrupt.
I,
That's their principle, because they say in order for us to get back the money, the person doesn't have to be bankrupt, because then you go back to this moral quandary: is how is he supposed to pay afterwards?
Yeah. Yeah.
But
Very, very different from the American system.
which I understand.
Yeah, very
It
different
has,
from the American.
but they have two different histories to
Yeah.
begin with.
Yeah,
I
for
mean,
sure.
Europe had, World War, and they were trying to find a way to cut, make sure that the people get up on their feet
Yeah.
and continue being productive.
Yes.
If that means we're going to cover a part of their treatment, okay.
Yeah.
But many of us don't see it only as, okay, we're getting it for free. No, actually, we're paying ahead of time
Yeah.
in case these things happen.
Yeah. Yeah, makes sense. So, yeah, little different there in the healthcare delivery system. So,
Absolutely.
now what's it like? What are the ERs like there? Are they, when I talked to you, he had a very different kind of model for his ER than what I was used to. Where, if I remember right, it was kind of one of those like, it's not one of the ERs where you take all comers. You're not. No, like not everybody gets to go to the ER.
That is that's what we call the Dutch model here in Germany.
Okay.
Because the Dutch are known for having the Dutch, and I think the Norwegians as well, they have this kind of system wherein you have freestanding ERs,
Mhm.
or they're somewhat affiliated to a hospital, but not
Yeah.
every single person gets to go to the ER.
Yeah.
Because they have a completely different delivery system wherein they have other doctors involved.
Yeah.
So if it's something that's actually just for a GP or for a normal doctor without urgency, then they would be whisked away into that sort of line.
Yeah. Like go. What I think a lot of people in America would like America to be is like go talk to your doctor about that. Go see your regular primary care doctor.
Exactly.
Which it wouldn't be a bad thing, because so many things that come to the emergency department in America could be taken care of by a general practitioner.
Exactly. But compared to the Netherlands, which is just across the border, unfortunately, we have the same kind of situation as you guys have.
Yeah.
We do have the option that, like the Dutch have, that you can send them to a sort of general practitioner instead of taking them up in the ER. We have sort of a because we use a different triage system as you guys. You guys use DSI, right?
Yep.
We use MTS, Manchester.
Okay. Which is real similar.
It's real similar. It's, I think,
more time based, if I remember right. It's more kind of based on time.
It's based on contact, doctor's contact. That means
like how soon that doctor contact needs to happen.
Exactly. Right? And I think ours is it's more symptom based, because we categorize according to symptoms.
Okay. I was thinking that the Manchester was more based on time than ESI, because ESI certainly is based on how urgent it is, how quickly they need to see a doctor. But I thought Absolutely. Manchester is based more on time.
They both have time elements into it. So, but how do I decide that a patient needs, because they're divided into categories, just like ESI, right? So, for example, if a patient comes and he is in complete apnea, for us, that means contact should start now.
Yep.
Right?
Yeah.
That is
see a doctor now. Yeah.
But again, that is symptom based. Or you look at the patient, and you see that the patient he has sort of an altered mental status. Oh, he can wait 10 minutes before the doctor sees him. Okay. So it's more. So we base it on the presentation, and we base it on the symptoms that the patient has. So you have presentation diagrams, and there are different kinds of presentation diagrams, from stomach pain to, abdominal pain to diabetes, for example.
Yeah.
And you have different symptoms within it, and these are your indicators.
Okay.
Say, okay, this guy, has a new weird pulse. It's not normal for him, so he has to get in right now.
Yeah.
In 10 minutes, he has to see a doctor, for example. Or, you know what? The patient does not fit in any of these paragrams. The patient doesn't have anything. It's blue, is in the blue category. That means 120 minutes. Yeah, the patient has to wait for at least 2 hours.
Okay.
So the problem is, in Germany, we try to use triage, but the thing is, for example, my hospital, we don't have the luxury of having a GP all the time.
Yeah.
We only have them 4 times a week. From then, I think they're only, for example, Saturdays and Sundays. They are from 10 in the morning till 8 in the evening. That means afterwards or beforehand, we have to take care of the patients when they come with non-urgent complaints. And when, or for example, on Wednesdays, yeah, only after 16 o'clock, that means 4 o'clock in the afternoon,
Yeah.
up to 10 in the evening.
Yeah.
So that means, again, beforehand, we have to take care of all patients.
And when you say we have to, that means the emergency physician, right?
That means us hold the emergency physicians. We don't have an emergency physician specialization, by the way.
Oh, really?
It's not yet there. We're getting there, but it's
Okay,
not
that's
yet made.
interesting. I had no idea.
We don't even have, this is actually something very funny. We don't have a specialization for emergency nurses up to a couple of years back.
Okay.
It's quite young, the
Okay.
specialization.
All right. Now, do you guys, so that specialization, is it still the CEN, or is there a different designation?
No, so for example, so the normal way that you do this is either you do 1 year, then you're a caregiver.
Okay.
Then if you do the 3 years after that, then technically it's not an academic structure, that is more of vocational.
Okay.
Germany is one of the only countries in the world wherein you have diploma nurses.
Okay.
So this modern day. I mean, you don't get a bachelor's.
Okay. So are most of the nurses that you work with diploma nurses, or are they?
Exactly.
Okay.
Most of them, it's like, I think I am the only one with a bachelor right now. They actually graduated with a bachelor as a nurse.
Okay.
So you have those 3 years. Then you can study for a bachelor, which is 3 years, and usually it's nothing to do with nursing in per se bedside.
It's all the gen
So
ed stuff.
Pedagogy, or you do business management or nursing healthcare management. That's totally in right now.
Yeah.
Of course, then you can do a master's, and that's it. We don't have advanced practice nurses in EDs.
Okay. But do you have advanced practice nurses, period?
It exists, but it's not completely 100% supported. Because again, the major problem is, it's kind of strange, because when one thinks that Nightingale actually studied here in Germany.
Okay,
she studied 30 kilometers away from me in Dusseldorf.
No kidding. Interesting.
Exactly.
Like nursing started there, but it's.
Exactly. But nursing in itself is still stuck in the 70s. In the sense that we don't have a nursing board. We don't have, it's in the coming.
Okay.
We're not 100%, we don't control our profession as we're supposed to compared to other countries.
Yeah.
Nursing is still a diploma course, a vocational course, and not an academic course like other countries, which again is kind of strange, because if you look all over Europe, every single one has a bachelor.
Yeah.
Then you look in Germany, you're like, what's going on there?
Yeah.
So right now, nursing in itself is changing. So it's kind of an exciting time to be in Germany, because you get to see this transition.
Yeah.
But the transition is not happening as fast as one would wish it to. And there's still so many misconceptions. They don't understand the role of a nursing board, and they don't understand the role of a union, for example.
Yeah.
But they cannot defy it, or a nursing association.
Yeah.
We're not to this point. There is no emergency nursing association per se. There is a emergency medicine association wherein nurses and paramedics are combined.
Okay. All right.
So it's more of an interdisciplinary association, but at the same time, I do feel that we are not focusing as much on our profession to develop it better.
Yeah.
But at the same time, we're not moving. It's good that we're together with the others so that we can focus on patient care.
Yeah.
And patient standards, which is great.
Yeah.
It's
a good thing. Yeah. Interesting. It's always interesting to hear how different countries handle stuff, because it's, you get locked into, this is the way we do it. This is the way everybody does it. And you're like, no, it's not the way everybody does it.
For example, in the US, you have more autonomy compared, for example, to a German nurse. A German nurse is not allowed to place an IV, for example, not because she doesn't have the training, but it's kind of implicit that you're supposed to do it. But if you're going to look at it from a judicial side, you're not allowed to.
Really?
Because that is a medical role. It's a medical responsibility, not a nursing responsibility.
So who does it? The nurses anyway?
It's kind of that implicit, you're supposed to do it anyway because you can't do that. And it's kind of funny because if I'm going to explain to you what are the premises that you can do something like that, you're going to laugh.
I can't wait to hear it.
There are 3 conditions.
3 conditions for a nurse to start an IV.
No, that a nurse can proceed with any single, let's say, responsibility or role or task.
Okay.
So the first one is the nurse has seen it being done.
Okay.
Right.
Fair enough.
The nurse has been, guided through how it's done.
Okay.
And the third one, the nurse has done it, and the doctor has seen the nurse do it, and it's correct.
Okay. So see one, do one, teach one.
Exactly. And that, according to law, is, except not teach one. More like
more see one, do one, be blessed. Right?
Exactly. So you kind of need it.
Now, boy, that just made every nurse in America go, what? Because like I can't imagine, like, physicians just aren't involved in nursing training.
Absolutely. In Germany, they sort of are. That is the problem. Like I said, they are not 100% separated.
Yeah.
If I'm going to compare the current situation, and we're going to look in the history books in the United States of nursing, it seems like we're still back in the 50s, 60s, wherein doctors come in and teach nurses, like, for example, here's the anatomy of the body, wherein we generally take care of our own courses because we've been trained enough to take care of it, right?
Yeah.
I mean, that was the experience I had in the Philippines because of the fact that you get it from your clinical instructor. Your clinical instructor explains everything and he looks at you're doing the things right. But here in Germany, the fact is doctors are so involved in the training that it's preposterous. When they do the final exam, because they don't do a board exam in Germany, that doesn't exist.
You don't do board exams?
No. So generally you have 3 people in the panel, they come in and they test you and to see if you are adequate or inadequate. So you have a oral exam where you're going to be asked, and generally there is a doctor on the panel, which again, as much as I'm really good friends with many doctors, I do think that is not their place.
Yeah, I love doctors. There's many doctors I love. I don't want them teaching nursing.
I don't want them testing nurses. That is not.
No, that too.
That is not the point. So, or like I told you, that nurses are not typically allowed to put IVs. If I were going to tell you in the middle of the night, what is the most common cause for a doctor's call, that a doctor would be called?
I mean, it would for now. It's a little different. Certainly, that's not an ER thing, but on the floors in the inpatient units, it was always a medication, always an acute change, and then a medication.
Right. For us is, oh, by the way, the IV is out. And second of all, so I saw on the patient's chart that the patient has a PRN medication.
That doesn't have an IV. Yeah. Oh, really? Yeah, I remember having when I was a house supervisor, I didn't have, like, I've always been an ER nurse. That's just what I've always done. And when I was a house supervisor, I never fully had the appreciation for inpatient nurses the way I did when I was a house supervisor. Like, the inpatient nurses I worked with when I was a house supervisor, they were badasses. They were really great, phenomenal nurses, and they took care of everything. Patient would come in, they'd take care of everything. Be like, okay, we're going to order this, and this, and they're going to call the doctor and go, hey doc, we just got this patient. These are the orders. I'm gonna put in. Do you want anything else? And they'd be like, oh yeah, add this or add that, or do this, don't do that. And they're like, okay, Roger that. But they would do 80% of it, like,
right,
with minimal orders. They'd be like, and the only time they called the doctor is if there was an acute change. And they're like, okay, like, I don't have a PRN to cover this. And if they did have a PRN to cover this, and they're like, by golly, yeah, she looks like she's in pain. Let's give her some pain medicine.
Right.
So they had a fairly more of an independent practice than I imagined, and they were good. They were like they took
They
care
were
of
on
stuff.
they were on their game, and they could
Yeah,
do their job. That is one of the reasons I get really frustrated when I hear these kinds of stories, because of the fact that, hey, you want to be recognized that you're a good nurse, but at the same time, you're not doing what you're supposed to do, or you're not giving the conditions in which you're supposed to thrive,
yeah,
right? So how could you expect someone who, for example, like me, I came from Italy, where while I was in Italy, I had 100% autonomy in my ward,
yeah.
do what I'm supposed to do.
Now, where did you start as a nurse? Did you start in Italy as a nurse
So, like
or Philippines?
I graduated in the Philippines, right?
Okay,
So that means I did my clinicals in the Philippines. So that
gotcha.
was like the start of the nursing process for me. Um, then I transferred to Italy in that was 2007, end of 2007, and that was the period wherein we had the great market crash. So I was in Italy. I was actually planning to study medicine, didn't go through it because of personal conditions.
Yeah.
Um, then I was in Italy. Okay, I was going to, I was planning either to go to the US, believe it or not, because I have a lot of cousins and aunts, typical Filipino family.
We got a lot
So
of Filipino nurses in Houston. Holy, there are a lot of Filipino nurses in Houston.
I don't want to say that all Filipinos are nurses, but there are a lot of nurses that are Filipino. It's a really, really strong sense of community that it's hard to explain. So like when I transferred to Italy, then I was supposed to come to the US. I took the NCLEX for New Mexico. I actually passed,
Oh, awesome.
but no employer would get me at that
Huh.
time because of the fact that it was the market crash. We're
Yeah,
talking about 2008
yeah,
with Lehman Brothers and everything. So I decided to work. Screw it. I'm going to try in Italy. It took a long time because of bureaucracy, which is a great problem in Europe. Usually, is bureaucracy.
yeah.
And I was working more on the down low for like private houses. So for example, I would go to someone's house wherein I would take care of a person, usually an elderly person who needs a little bit of help, or I would like post-op patients or pre-op patients.
Wow.
But usually that was like under the table kind of
Yeah,
situation.
yeah.
Eventually I got a job in Italy, and I was working in a care home as the nurse, which was an amazing job. I thought it was going to be really, really hectic or whatever, but it was amazing because all I had to do was make sure that all the inhabitants of this care home all got their medicines, made sure that they're scheduled up for medical visits, and that was it. That was my job.
Wow. Okay. You're like, well, fairly easy.
It
So,
was completely. So it's kind of like I started out. I was doing paramedic job, this paramedic volunteer job on the side. I was working this care home at the same time. So I had both extremes. So 100% adrenaline,
and
and
100% not.
well, let's just put that I read a lot of good books in that time period.
Nothing wrong with that.
And I had amazing conversations because, you know, older Italian people have very interesting conversations that I have to admit.
That. So,
Especially when they're trying to introduce you to their grandchildren and you're like, no, thanks.
you're like, no, I'm good. Thanks, though. Appreciate it.
Yeah, exactly.
They're all trying to fix you up. Funny.
So then it was to the point I was, really tired of Italy because of the fact that getting a job in Italy in healthcare, especially in the public system, is almost impossible
Yeah.
because they actually have a competition system.
Really? Huh. Okay.
So because okay, what's the one thing that all nurses wish for a contract in the US, for example?
I I I think there's a lot of different things. I think there's, is it a days off thing, or is it nights versus days, or
For Italians, the best contract you could ever have is a permanent one.
interesting? Okay. Like, so what do you mean? Well, like, what do you mean by permanent? Because I mean, I don't think much is permanent.
Well, we say permanent in the sense that there is a sort of system in law wherein you apply for a job and you could either be permanent or non-permanent.
Okay.
Permanent jobs means that you always have this job as long as you want to keep this job. And after a couple of years, this job is permanent in the sense that unless you do something incredibly stupid,
Yeah,
you're untouchable.
Interesting. Okay. That's, certainly it would be a thing that people want here, but like I find most people don't want to stay at a job that long.
I think that it's also a cultural thing.
Yeah.
Because you have to take into consideration that Italians are very, I want a job, I want to earn money, have my little vacations, but I want to settle down, have a house, have a wife, children, go on, right?
Yeah.
So it's a very sedentary thing. As much as possible, they would even apply for, like, for example, people from the South will apply in the North, because once you're in the public system, you can be transferred to the South. Okay. That's not a big deal. Yeah. You can always transfer to the South.
Yeah.
So, and the job is permanent.
Interesting.
That means, hey, you're working, for example, in Sutterol in the Alps. Okay, you're tired of it. Why don't you go down to Sicily? You can get transferred.
Yeah.
And the job is still, you're not going to get fired. You're just being transferred to another hospital, and you still have the same conditions.
Wow. Well, that's kind of cool. It's kind of a good thing, and I mean, I think the closest to that we have would be like if you get a job in the federal system. Like if you get a job in the federal system, you're unless you do something really, really egregious, like you're gonna have your job till you retire, and then it's a true retirement, which most jobs aren't, where you're paying into it, and then like, okay, you're gonna get a retirement check once you're done. So
that's the same principle here. I mean, that is our equivalent of the federal system.
Yeah.
For the Italians, for example. In Germany, I mean, when I tell people that I have a permanent contract.
Yeah.
Because I can say, I don't want to work for you guys for just 2 years.
Yeah.
You can actually demand it in front hand because of the fact that nurses are such a hot commodity right now because we're all understaffed. We're in such a situation that I think it was 2019 that the entire country actually came together and said, this kind of healthcare system is not going to work anymore.
Yeah.
I mean, not every single patient has to come to the emergency department.
Yeah. At some point, I just can't help but thinking that at some point the U.S. is going to realize that too. So I don't know, but because what we have now is not sustainable.
Absolutely. The thing is, if I'm looking in Germany, the fact that, I mean, if it weren't for COVID actually changed everything. It made everything slow down.
Okay.
For the first couple of months.
Yeah.
Which for many of us, we were a bit confused, annoyed, irritated. Like we didn't really understand what was going on. At the same time, I was one of the people who said, you know what? Let's just take this as a work vacation. Bring a good book, sit down, relax.
Yeah, you're like, let's just say thank you and move on.
Exactly. And then all of a sudden came summer. And all the really sick patients started coming in.
Yeah.
Not with Corona or with COVID. They came in because you have your heart problems that actually decompensated to the point that they needed to be brought into the hospital. Or you have, I think that was one of the weirdest cases. I had 3 or 4 patients with diabetic ketoacidosis, which I've never had in like years.
Really? Wow. Huh. But probably because they're managed, like they're managed, they can go to the hospitals. But we've seen the same thing here in America, where when coronavirus first really started, like people were not going to the ER. Like people were like, and they were probably sick enough to where they needed to, but they just weren't going because they were afraid to go there. They were afraid they were going to get coronavirus and die. So one of the big messages that that ENA was really trying to kind of push, and so were the states were we'll keep you safe. We'll keep you safe while you're here. Like if you need to come. Don't die at home for something that we could have maybe treated you for.
Exactly. I mean, I think that was the problem because of the people were so reluctant, even just to go to the normal GPs,
Yeah.
that when they came to us, they were in such a state that you would say, okay, if you came in a month earlier, I think you would have survived this.
Yeah, you'd probably be okay. Yeah.
Right. And so you have this kind of situation. And right now we are in a middle thing. That means we're having patients. And there are patients with really, really strange mixed up conditions. Either you have the nothing, that's what I call it. You come in with an ingrown toenail, okay, that's a nothing.
Yeah. Yeah.
Sure, it hurts. It is an emergency because according to German law, there is no legal definition for an emergency. That means the emergency is what the patient feels is an emergency.
Same. Yeah.
Then you have the patient that comes with the normal things, chest pains and whatever. And you have the patients that are just so far blown out because they never left their homes because of the fact that we're scared. So,
Yeah.
and what is great also is the fact that COVID actually changed the ways we're handling EDs. We're not allowing so many, significant others into it.
Yeah. Us
We're
too.
saying, who's the patient? Can the
Yeah.
patient speak German? Yes or no? Okay, the patient only. Or cannot speak German? Okay, you can come in as a translator. Kid? Okay, parent. Only one parent, period.
Yeah. We're
And
a lot of ERs in America are doing the same thing. Like they're just trying to limit, and part of it's protecting the patients and protecting the staff, right? Because we don't have much that we can do to protect the staff besides try to limit their exposure.
Exactly. But what's also amazing is the fact that that has alleviated, the triage process at the same time. Because as triage, sometimes you're also responsible for the waiting room. And when you have thousands of people there, you lose track.
Oh, it's hard. It's hard.
Right.
Like right now, nursing's hard. Like nursing's hard right now. Like people are getting their souls crushed in nursing that they're just, it's hard. Like I don't know how it is for you guys, but we're short staffed almost everywhere. And everyone's just kind of getting their ass kicked with COVID. So that kind of a tough time.
Absolutely. The fact is that we all trained in what would we call as the beautiful summers of yesteryear, and now we're facing the real winter.
Yeah. It's a much more stark difference than I thought it would be. Like, and we for here in America anyway, it's right around the 1 year anniversary of when we've really been dealing with COVID. Like a year ago, we were all kind of saying, okay, if we could just shut everything down for 2 weeks, we're going to be good. Like
if we did,
yeah,
that's the problem.
And I wonder if we did, if it really would have. I'm not sure. But of course we didn't, and we couldn't, and we didn't, and we wouldn't. I shouldn't say we couldn't. We didn't. And certainly other countries did. Certainly other areas did.
But I think the only countries that were able to actually get out of this entire mess were Australia and New Zealand right now. Yeah. They're the only countries that were able to do so because they decided to go headstrong right into it and say, you know what, we're going to shut down one entire month until it's really down.
Yeah. And really knocked it down.
The rest of the world, Europe, did the same mistakes as every other country, saying, the economy must not suffer. Sure, there are long-term consequences, but right now we're still in a very long-term consequence.
It's just been, yeah, right. I mean, so it's been a year. It's been a year since we've been dealing with it here in America, and there's no signs of stopping. And now we have the nonsense that Texas is doing, where Texas is like, oh yeah, we're gonna just, we're gonna open everything back up, and it's been pretty much open anyway. The only thing that really wasn't open is restaurants were being capped on their capacity, and bars were not open. Like bars were the only thing that were still truly closed in Texas.
Which I don't find. The thing is, I'm not really sure. The thing, when one takes into consideration that alcohol changes how one's perception of danger is, then yes, I understand why bars have to be closed completely, 100%. Again, restaurants, same thing, but I'm not sure up to what certain point.
Yeah, it's one of those that like. Now, here's the interesting thing is like there has been almost no flu. Like flu season has been like flu season hasn't been flu season in
We
America. I don't
had
know. Did you
we
guys
had
have
only
much of flu? Four
we had
patients.
only 4 patients the entire time because we were so certain they had COVID, but they tested negative
Yep.
and say, you know what, let's just do a influenza test. Let's just see what they have. And they had it. And they were the only ones that I've ever heard the entire time that we've been working on the COVID situation the entire time that they were actually positive for influenza. I haven't heard any other case.
Yeah. No, we haven't. We've had very, very little flu. We've had, probably more than four, but certainly not what we usually have. But one of the things I said is like that really makes the case for social distancing. That really makes the case for wearing a mask.
Mm-hmm.
And it just makes me think, okay, next flu season, whether or not we have COVID under control, like, is everybody going to start wearing a mask on flu season? And my guess is a lot of people will. Maybe not
Because it's
everybody.
ingrained.
Yeah,
Because it's
maybe.
ingrained.
Yeah, maybe not everybody, but certainly a lot of people will. And
Absolutely.
so, but it's this COVID thing has been a little bit of a mess. So
It changed us all. That's what we can say.
you're absolutely right. It has changed us all. Do you guys have long wait times in your ears?
I would say that's a yes and a no. The typical German Jaien. So it is a word, right? It means
Okay.
yes and no.
Okay.
So
Jaien. I love it.
so it's kind of like saying we have patients, they're seen according to triage times as soon as possible, unless we have too many when we have surge moments,
Unless it
right?
just doesn't work out for us.
Right. And but I think our major problem is because we're so interdisciplinary. We don't have one emergency specialization, right? So we have internal medicine. We have, for example, my hospital, we have internal medicine, what we call as trauma surgery, but they're actually not trauma surgery. They're more of like a specialized orthopedics. Then we have the general surgeons, we have the urologists, we have the neurosurgeons, and we have so the ENTs as well.
DNTs.
ENT.
Oh, ENT. Yeah.
Yeah. So they're with us as well. So it depends if we're going to present a patient, for example, with nausea and tinnitus, right? So you're going to say, oh, I'm going to present it to the ENT. Said, yeah, but you have to look how the patient reacts. So for her, it's more of a central thing. It's not because of the ears. So it's going to be, given to the internal medicine. So this is the problem. When they're tossed from here to there, then the treatment itself becomes frustrating, not only for us, but also for the patients themselves.
Yeah.
And we try our best to limit that. But it has happened that we have someone up to 7 hours.
Yeah.
Just because of this, we're going to give it to this person because I think it's not for me, or it's not for my specialty, right? The most famous ones are usually the neurosurgeons. They love to give it to someone else, unless you have a proper brain bleed and they cannot say no.
Yeah, unless is there blood in the brain, then call me. If not, so all those are consults in the emergency department, or are they stationed in the emergency department?
They, for example, we have those who are stationed, properly stationed. So they are they're not complete. What do you call them in the US? So generally you have your lower residence, and then you have, after the residency, you take a test, then you're specialized.
Yeah.
Right. So, and in Germany, it's a completely different hierarchical. You have a different hierarchy practically. So you have those who are still learning, those who have passed the test but are just working as assistants. Yeah. Then you have those who are like proper residents and consults. They stay there, and then after that, you have like the head of the entire department.
Yeah.
So generally, those who are learning and those who have already specialized can be stationed with us.
Okay, but it's the different specialties. So because you don't have an emergency specialty, or you do have an emergency specialty for physician.
It's coming. It's still coming. It doesn't exist yet.
Yeah,
that's the problem. I mean, we're still changing, and But the problem is we don't have one person who is like a jack of all trades.
Yeah.
That doesn't exist.
Yeah.
We have like mixed specialties, and we're truly in the only people who are interdisciplinary in our emergency department are actually the nurses.
Wow. Huh.
Because we are the ones who can say, okay, you know what? The patient has this, 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 and this, right? So we're the ones who actually say, you know what? For me, that is a general surgery problem. The patient has an acute abdomen. That's technically a general surgery problem. It's not an internal medicine problem. We get to decide based on parameters and conditions. What happens afterwards? We always say we try our best to make sure that the patient gets proper treatment, but it's actually doctor's responsibility afterwards.
Yeah. Gotcha.
So, I mean, that is the only thing that I could say that is a plus on our side. That's the only autonomy we actually have.
Yeah. It's kind of the disposition.
Yeah, it's to say, okay, I saw this patient. This patient is weird. I think I'm going to call the neurosurgeon.
Okay.
That has happened once or twice. Of course, I had to, discuss with them until the point I said, either you come down or I will go up there and pull you by the ear till you're down here. That has happened once or twice.
Yeah.
And of course, for me, what's very important is that we have to always take the patient into consideration. That is, at the end of the day, that is our job, right?
Absolutely. Absolutely. What do like are nursing wages good there? Like is it nursing a good profession there?
It's well, compared to the United States, we have to take into consideration we have different living costs, right? So, for example, for me, it's an okay. I mean, I'm not going to get rich from it.
No.
I'm never going to get rich from it.
Yeah.
But I can live a comfortable life and have vacations as much as possible. Of course, I do have to take other things into consideration. For example, I'm renting a really small studio apartment so I can travel more.
Yeah. There you go. Like,
so
it's the give and take, right?
Exactly. But I mean, for example, for a nurse in my level, because right now I'm doing a specialization, believe it or not. I don't want to, but I have to.
What do you mean you're doing a specialization? So
I'm doing the emergency nursing specialization. It's being paid by the hospital. So
okay.
I'm like, okay, I'll do it. So, and afterwards I get the change in tariffs. So that's also good. But
the change in what?
We call it tariff.
Okay.
So for example, every single nurse has a tariff.
What does that mean?
So that means if you're going to start in nursing in a hospital, especially if it's it depends if it's public or private. Both of them have tariffs. They're different, but they exist. The tariff is the one that will tell you how much you earn per hour.
Okay.
Right. So I'm expected to do 160 hours. I would earn around almost 30 euros an hour.
Okay.
Right. Pre-tax.
Okay.
Post-tax, is a little different.
Totally different story.
Exactly. Like always. So for example, I a nurse in a specialist area. The emergency department is considered in a specialist area. So I get a different tariff compared to my colleagues on the floor, and med surg floor.
Gotcha. Okay. That's good. It's a good thing.
Exactly. And if I get the specialization done, I go up tariff.
Okay.
So do you actually look at how much education you make? You take afterwards. If you decide to go to do a master's, you go a bit higher. You do a bachelor's, you get higher.
Okay. So it's kind of similar. It's kind of similar to America in that way. Like same thing here. Like if you have an associate's degree versus a bachelor's degree, you're just going to make more.
Exactly.
If you have a master's degree, you're just going to make more.
The only difference, I think, is that ours, you can actually look for it online because the tariffs are always published every year.
Okay. All right. The now when you say you're doing a specialty, is there like a test for that, or is that or is it just do you like if someone? I'm sorry.
I'm excited. I'm actually excited for it because it's 2 years long. I already did my first year.
Is it a training thing, or is it a certification thing?
It's a mixed thing. So you have a 2-year period wherein you're supposed to fulfill a number of hours.
Okay.
Right. So I have to do at least 920 hours in an emergency department. But I also have to rotate and go into ICU, anesthesia. I have to do paramedic work as well.
That's cool.
And 300 hours, I can choose whatever I want to do. If I decide, you know what, I'm going to do, the heart characterization, how do you call it in English?
We call it cath lab, like cath
Exactly.
lab, where they go do the heart cath.
Exactly. I mean, it's almost in German. Why am I thinking too much? So, right. So the cath lab, or I could decide, I'm going to go to labor and delivery, which I'm never going to do. I can decide. And I actually signed up for a CAD, what we call as cardiothoracic surgical intensive care unit in another hospital that's famous for it.
Oh, that's kind of cool.
I applied for it. I'm waiting for a call. So it's kind of interesting because you have to do practical things. You have a test at the end of it. We have tests in the middle of it, and we also have to write papers.
So it sounds like certification, kinda.
It is a certification at the end, but in the middle, you have all these kinds of blocks along the way. For example, you have to make sure you have your practical part already done, your theoretical part already done. The theoretical part are going to look, okay, did he pass all the tests that are necessary per module?
Yeah.
Right? So I wrote to you that I was going to take a test.
It's in May.
Okay. But I'm studying ahead of time because the topic is very, very short, but too much.
What is it?
So I have, we call it cardio, neuro, pulmo, and sepsis.
So like
together with EKGs, mech vent, and ABGs.
So it sounds like critical care is what we would call critical care.
Yes, but that's just one exam.
Ooh, big exam. Okay.
And it's not multiple choice; it's open word.
Oh Lordy. Okay, it sounds a little harder than we had to deal with. So
yeah,
that's cool. That's really cool.
So, I mean, and this is new, right? It's actually modeled a bit on the, for example, the critical care nurses, for example, ICU and anesthesia. They have this kind of structure, but theirs is more or less 12 years old. Ours just started a couple of years back.
Okay.
So it's interesting.
That's kind of cool. You get to be, it's kind of cool. You get to be kind of at the forefront of that.
It's fun, actually.
Yeah.
I hate going to theory, but that's, I think, every single student's problem.
Thank you for all your time. This has been an honor, and it's been great. And I can't wait to do more with you and keep in touch with you.
Absolutely. Same here.
But what I really hope that the ENA can still get together in Florida or in Orlando.
Yeah.
I really want to do that.
I'm seconding that. The fact that we have created community online, sure, but it never beats actually seeing someone face to face. And as the proverbial Germans say, each with their beer in their hand to discuss the things of the world.
Yes.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.